who's one of my colleagues from the Wessex Cancer Alliance, who's got a particular interest in bowel cancer and clinical genetics. And Nikki's going to do most of the presentation. The reason that we're running the presentation now is that it fits in with our campaign to increase the early diagnosis and presentation of bowel cancer. So the Wessex Cancer Alliance had got, last year they had loads of money, this year they've hardly got any. And last year they thought, what can we do that puts most improvement in cancer care across Wessex? And they felt that bowel cancer was the thing that would make most difference. And areas were invited to submit applications for improving care across their patch. Nikki and I were sort of very much in the let's get everybody on board and share it evenly, but in fact the Cancer Alliance thought that they'd rather target it to people that put in the best application, and Peter and his team actually must have put in a really good application, because they've got proportionately probably more money per patient than anywhere else in Wessex, which is pretty amazing. And so they've set up a campaign, and we'll talk a bit about that, and we'll talk about bowel cancer in general. So I'm going to let Nikki drive the slides, because okay, so this is what we're going to talk about. We're going to talk about why colorectal cancer is the thing where we might get most bang for buck in terms of making improvements. And bowel cancer, you probably know, is the third commonest, so it's right up in the top ranks of cancer, but actually it's the second commonest cause of premature death, and it's only beaten by lung cancer. And there's some important things about its incidence and prevalence, which we'll come to in a minute, but actually in terms of making a difference, it probably beats all the other cancers combined in things that we can do to improve things. And that's largely because of the fantastic advance of having FIT testing, which we're only really beginning to use properly in clinical practice, and Nikki's going to talk a bit about that during the presentation. So I'm going to hand over to Nikki, and then you'll be hearing a bit of me later when we talk about the local campaign. And if you've got questions, either put them in the side, or if it's really pressing, then just butt in. Okay, over to Nikki.
All right, thanks, David. So I'm the GP in Southampton, just across the water from you guys, deal with a similar population, quite a lot of deprivation. But why bowel cancer? And I think David's alluded to it. It's a common cancer. There is a really good screening test, but there's also a very good diagnostic test that we can use to try and pick people up at an early stage. So why bowel cancer? So let me... just making sure the slides move on.
So I can drive it if you want, Nikki.
Yeah, have they haven't moved. So
no, okay.
Okay, there we go. So it was really just to say that colorectal cancer at an early stage is curable. If you've got a little polyp that's become into a cancer, you can remove it and that patient is cured. So you're not getting to those very late stages where the outcome is pretty dire in some cases. But if we can pick people up early, it makes a big difference. Let me... Is it? There we go. Going too quick. Sorry about the tech here. So this is a really good infographic from Cancer Research UK, and it looks at where are we picking people up. And on the left-hand side, you can see we're only picking up about 10% of colorectal cancers through screening. So the majority is still either coming in through a faster diagnostic pathway, or the 2-week wait as it used to be called, a routine referral, so that's just over a fifth of patients. But what is quite sad still is there are a lot of people presenting as an emergency. And if they are presenting as an emergency, as you can see on the right-hand side, generally those are later stage of diagnosis with those poorer outcomes. So what can we do to try and shift it? Why the variation? Well, we know age is the biggest factor. The older you get, the more likely something would have gone wrong, and the higher the chance of you having a cancer such as bowel cancer. Deprivation, whether that has an influence on your life outcomes, and we certainly know it does, but just thinking about your diet, obesity rate, alcohol, smoking, all those things. Then we've got the time and the route to diagnosis. So actually, which way did you go in? If you're going in as an emergency, chances are it's going to be a later stage, and then also the stage of diagnosis. So there's lots of variation. Then we went away, and I didn't personally get involved with this, but it's a really good publication, and it looked at what was the awareness amongst the public of having a bowel cancer. What are the symptoms of it? And actually, as you can see, there's lots of patients who don't know the common symptoms of bowel cancer, and then they've broken it down how long they waited to go and see a GP. And lots of people didn't know the symptoms at all. And that's quite sad. And I think your campaign in the Isle of Wight, which we'll come to later, is really pushing some of that message out to the public. We've then got the number of times they go and see their GP before they ended up with a diagnosis. And as you can see, we're doing a great job. Over a third are only seeing the GP once and having an onward referral. But what about those patients who are seeing their GP more than 5 times? And there's lots of unpicking needs to be done there. Is it that we're not giving that patient the right investigations? Where often there is a message that goes out, and it came out of this publication where it said, you're too young, you can't have bowel cancer, and they often label that patient with other symptoms, with another diagnosis, such as just saying, well, you've got IBS, when they had a change in bowel habit, and that they had other things going on. So actually, it's just making us more aware of having a bias of the age of the patient coming in. And I think we're all aware of that, but it's just that came out of this report. I've put a toilet here. This is before your campaign on the Isle of Wight, but it's just to make sure we are clear. In this country, we don't talk about our poo and going to the toilet. You go to the continent, you go to Germany, Austria, toilets are designed differently. People see their turds. They talk about it. They pick up worms earlier on. And actually, I think unless we make it, this is bread and butter stuff we talk about, people aren't going to go and seek out medical opinions and get it investigated. Then there's the national campaign. So this is a really good one, and I've got this up in my room, is actually tell the right person. It might be that that person at the supermarket checkout says to you, actually go and see your GP, not, oh, that's interesting, and doesn't do anything with it. So if you've got symptoms, go and talk to someone. And this is another example of what happens. So your stage of diagnosis, on the left, stage 1, which is where we want everyone, or ideally even before you get to a cancer, your outcome's pretty good. But the later you are on in that stage of diagnosis, the poorer the outcomes. And you can see that kind of the dotted line that goes across is your survival rate. And the later the stage, you're not surviving long. And that's both the 5 and the 10-year survival rates. Red flags. Now, I don't know how old you are all on the call, but back in 2005, there was a set of nice guidance that came out about who to refer for colorectal cancer. These were the red flags. If you look back at them, I think we often turn over in horror thinking it's missing lots of the primary care data that now drives our local NG12 guidance. So where you've got someone with anemia, that was a reason to refer. But actually, we now look at lots of other primary care data, abdominal pain, change in bowel habit, your platelets, those sorts of things. And that drives the new set of guidance that we've got and we refer on. Many of you might use some tools. So this is one of the ones down in Exeter from Willie Hamilton. So this is a risk assessment tool. And what it looks at is kind of if you've got a symptom, what is the chance of you having a colorectal cancer? And then if you present with another symptom, you kind of read across. And as you can see, if you've got a hemoglobin less than 10 and abdominal pain, you've got a positive predictive value of 6.9. So it really is a helpful tool. And lots of these are available in the public domain. There's another one called Q Cancer, which Julia Hipsley Cox has got up in Nottingham, and that has been embedded in some of the IT platforms. We haven't yet got it in System 1, but it is there within EMIS. But these are really helpful to help guide when we're not quite sure what's going on with a patient. And then we've got our FIT test. And they are really helpful because what we can do with it, we are looking for blood in the poo, blood that we don't see with the naked eye. And we'll use this for a variety of reasons. We're using it for bowel screening, but we're also using it for symptomatic patients, including those with rectal bleeding. And we know if you've got a normal full blood count, so you're not anemic, and your FIT is less than 10, the chance of you having an undiagnosed colorectal cancer is less than 0.1%. So that is pretty low. So it is a very good test. Back in 2023, there was a project put together across the whole of the country where trusts were given money to roll a FIT less than 10 pathway. It was short-lived, and the idea was to start getting everyone to think about doing a repeat FIT where we've got patients who present with vague symptoms and actually the FIT's less than 10, the full blood count's okay, but we just safety net them and pull them back. And if you have 2 FITs less than 10 and you have a normal full blood count on both of those points of contact, the chance of colorectal cancer is less than 0.04%. So that is pretty low numbers, and that has been replicated when we've looked at some of the data in Wessex as well, which is really good to know that actually this is a reliable test. Nothing is foolproof though, and if you see someone that you're thinking, actually I'm still worried, get on and refer. But I think that's a clinical decision which pathway you go down to. We can talk about that later if needed. So the National Bowel Cancer Screening, you have to be registered with a GP. You get sent the kit in the post from the age of 50 now, so it's been a drop. It's offered every 2 years. If your patient misses that appointment for whatever reason, and it might be just choice, they can ring up the national number and they will send a kit out. You can phone up on their behalf as a practice and say, actually, could you send one to Mrs. Jones? And they will do that. After the age of 75, you will not be invited in, so you won't receive a kit automatically, but you can continue to have a bowel screening if you wish to, but you have to proactively do that. It has also picked up our Lynch syndrome patients, which we'll come on to later, but they are, rather than being sat within your local trust, they are being offered their screening, and that is a colonoscopy, not the poo test, through the National Bowel Cancer Screening. And that means if they move GP practice within England, they're picked up. And that's working really well. Now, if I do a FIT test, and it comes back that I've got blood in it, it is reporting back at a much higher level at 120 at the moment. So less than 120, we don't do anything. Greater than 120, I will be offered further investigations. So 97 to 98 people out of 100 won't need any further testing done. But there's a few that will be invited in for a colonoscopy. So that's a more in-depth screening rather than just doing the poo test. So again, just one of the other posters that came up that is really helpful. And this is just to reaffirm where we use FIT. So we've got the bowel cancer screening. We've got where we're using it in GP practice, where we've got someone who I'm worried needs to be investigated further with bowel symptoms. And that is easy to do. We give the kit out from the practice. We're the ones who get the result back. And then you might even find that patients are having it done within secondary care as part of a filter test, or you might require it in some of the other cancer referral pathways, such as the RIS referral. So what is a positive fit? So if your level is greater than 120, that is positive within the bowel cancer screening. But for the diagnostic or symptomatic fit, it's reporting back a greater than 10. I know for the Isle of Wight, you may get a level back of 8 or 9 or 7, but actually it's really important. You do not need to do anything if it is recording back at those levels. It's only when it's greater than 10 it's classed as being positive. And if you have any questions about that or you're concerned, speak to your local secondary care providers, the colorectal team, who will be able to guide you if there's any queries about that. And I know David is very well aware of that discrepancy between the island and the rest of the mainland, just on the system you've got in place at the moment.
Our lab isn't NICE compliant.
Okay, so how can FIT help? Well, it's a brilliant tool. It's easy. Patients are happily doing them, and it's not that difficult. There are some dexterity problems, so if you can't open the vial to get into it, making sure you've labelled it properly. There are certain groups that might struggle, so if you are visually impaired, you might struggle. So it's just thinking around how you can help that patient to complete it. It's got a high sensitivity and a high specificity. It's really good at risk stratifying. So one of the things is a fit that is very high, greater than 200, is very likely to have some pathology going on, whereas one that might come back at 27, and that would instigate a 2-week wait or faster diagnostic service referral, actually they are probably lower risk. Doesn't mean they haven't got a risk of bowel cancer, but it's lower, and it's a really good way for the hospitals to try and filter out how quickly they get people through the system. So is it a good test? I like this slide because it just reminds us of what a good test it is in compared to other tests around, such as your CA125, your PSA and your chest x-rays, where actually we're still missing a big chunk of cancers. This is just going back to the thresholds. The higher the level, the higher the risk of you having an undiagnosed or cancer going on, or colorectal cancer. So just a reminder about the use of the symptomatic fit, and I think we're all pretty au fait with it. It's been around for a few years now, and pretty much everyone is just automatically doing this. So this is just a really helpful little flow diagram of the fit less than 10 pathway and what we need to do. So kind of on that repeat fit, and it's just a nice way of reminding us what we need to be doing. So if you're ever worried or you're not sure, seek advice. That is my message. So there's no harm in asking a colleague within the practice or making sure you safety net that patient to come back. So which referral pathway? You've got your asymptomatic, so asking, so this is more in relation to a patient who just pitches up and says, I'd like a fit test, actually exploring why they want one. So is it they want screening and they've just come to the wrong port of call, or give them the number to get on and call up for a kit? They might have a strong family history of bowel cancer. Doing a fit is not going to be the right option for them. Actually contacting the local family history clinic, because they will need more in-depth reviews, a colonoscopy. If they've had a private fit done, because we do see that with lots of companies offering it to their workforce, and actually what do? One, we don't know if they're NICE compliant. 2, we don't know what level it's reported back on. And when we've discussed this within the wider colorectal team, the advice is repeat the fit, so we've got it, but also just unpick, have they got any symptoms? Is this an opportunity for a bit of education? Do we need to safety net them? And just follow that up. And then making sure you've thought it through. What symptoms have they got? Do they fulfill the faster diagnostic service referral? Do you need to do a DRE? Because not every 2-week wait referral for colorectal needs a rectal examination. If you've got someone who's got a great big mass in their abdomen that you can feel, is it going to make a difference? not necessarily. It might be good practice to make sure that you're not missing something in the rectum, but just getting on and referring them and thinking about the IDA pathway as well. So that's the iron deficiency anemia, because they need to go down a slightly different route, which I hope colorectal would make sure happens, but it's very easy to put them on the wrong pathway. I've been caught out recently where I've just ticked the wrong box. It can happen. So what is required? You're going to make sure you've informed the patient of the need that you're referring, making sure you explain that it is going to be a fast track referral, safety net them, ensuring that they know that they need to come back after that appointment so you can check what the outcome is, because they might have a negative colonoscopy and told you don't have bowel cancer, but actually there might be something else going on. Making sure you've done the appropriate bloods at the time of the referral or just prior to that, because it's going to help in terms of which pathway they go down. If you've done your full blood count and your ferritin and they've got an IDA picture, they go down a slightly different pathway than if they've got a rectal mass. Making sure you've done the FIT and then the safety netting. We talked about that new pathway in terms of the repeat FIT, and that's just a summary of what we need to be doing, and I'm sure you all are. So why do we get colorectal cancer? Well, there's a whole load of things, isn't there? There's lifestyle, smoking, alcohol, processed food, red meat, then thinking about diabetes, obesity, those with inflammatory bowel disease, increasing age, E. coli exposure in childhood, and then genetics. This is a recent publication that has come out looking at our younger adults, and I just wanted to highlight, you can see on the graphs on the left-hand side, there's this kink that happens, and it looks like those born in the early 1980s are in that cohort where the numbers of colorectal cancer seems to start climbing, and it is doubling at a constant rate. But what we need to unpick is why. And then the little map of Europe on the right is there are some countries where it is very clear we have had, I think it's between 5 and 6% increase in the UK. And it's trying to understand it, because I think if we can understand it, one, we can try and prevent it happening to future generations, but also ensure that we make it, raise the awareness of colorectal cancer in that group. So there's obviously gaps in the data. You can see on that graph, not every European country has filled it in, but we've got those risk factors. We've got the increasing weight, the alcohol, excess nutrients, raising awareness, identifying the factors behind it, and then the screening. So what can we do as a GP? Well, I think there's lots of campaigns out there. The Never Too Young campaign is one where it's looking at those people under the age of 50, and you can see that people are coming to see us as healthcare professionals, and actually we haven't always listened or investigated. So it's really important we take age out of the equation when these patients present.
So it's on to me for a few slides next.
Yeah.
So you'll be aware of our local projects. You've already done some sterling work in sending Accurexes to our patients, and we've had nearly 9,000 replies for the Accurex, where we asked patients if they were aware of the symptoms of bowel cancer, and we've replied to those patients with the correct answers, but our answers were pretty much along the line of the things that Nikki showed you earlier, with about sort of 40 or 50% being confident of the symptoms, and if we can increase that to 70%, then we've got a good chance of people coming to us earlier. You're going to be given some audit work in terms of your referrals for bowel cancer, and that will be coming through at your next Liz meeting. You may have seen the beginning of the campaign, which has been rather more successful than I hoped it would have been, really, because it's been picked up by the BBC and it's been picked up by the county press and it's being picked up with the Ireland Observer, and we sought the Federation sought some advice and sought some help from a publicity company, and we put these toilets out in various places on the island, and it's actually had an amazing response in terms of media coverage. Not necessarily all the response I wanted in terms of getting the message across, but it certainly seems to have triggered up quite a lot of interest. We're going to continue this awareness campaign for a few months. There's going to be notices, believe it or not, on the number 2 bus route between Newport and Cowes, and we'll see a mock of that in a moment. We're going to go to events with this campaign, to local events rather than the events like the Isle of Wight Festival, because we want it to target our population rather than the general population, although the decorated toilets has already obviously made it to Southampton. This is from the county press, and that's just sort of coverage that we were looking for. So we've got a picture and we've got telling people what to be looking out for. So we were really pleased with that. So I've mentioned this a bit already, but you're part of one of the local presentations. We also have got videos for employers to give to their employees as part of the health campaigns, and we're going to engage with lots of communities. So it may end up more people presenting to you, but if we can get people diagnosed at an earlier stage of bowel cancer, I'm sure it's one of those things that's going to be really well worth it. A couple of things that come across regularly are, before you make a diagnosis of IBS, it's well worth doing a CA125 and a FIT test, because they're the ones that people come back to us when I see patients in the hospice who've had a delayed diagnosis. Those are the things that little traps we've fallen into. So it's a sort of top tip from me to think about doing those 2 tests before you make an IBS diagnosis. So this is the mock-up for the bus stop. I'm glad the squirrels haven't got a copyright, otherwise we'd be in trouble, but they've already come up with some great posters and adverts. There's the circle there is a beer mat or a coffee mat, and I trust that you'll be trying to collect those in your local beer and coffee places. We're going to distribute them around. So we're going on to some more recent stuff, which Nikki's going to talk us through in a moment, and I'll hand over to Nikki now.
Right, so it was just a little bit of horizon scanning on where medicine is at the moment, because when you go off to medical school, you learn lots of stuff, and then you become a doctor, and lots of all that headline stuff kind of you lose track of it unless you're working in that field. And it was just to really say there is lots of projects going on at the moment. Some of them are running out of Southampton, where they're trying to pick up bowel cancer at a very early stage, where they're looking for circulating bits of RNA in the bloodstream, or the particular groups that are much higher risk. So if you are someone in a high risk group where you've got family members who've had bowel cancer, you might be invited in and under a specialist unit. And Southampton is one of 6 units across England that run those high risk groups. And then your treatment options might be very different if you have got a specific gene defect causing that colorectal cancer, and then even thinking further ahead in prevention, if we could stop those patients getting bowel cancer in the first place. There we go. So just back to a little bit of, quickly, you saw the chromosomes there. My question is, are all cancers genetic? And I would say yes, because something's gone wrong with the DNA. But actually, that's the DNA within the tumour. There are certain patients or people who have had something go wrong with their DNA before it even gets to that tumour that grows. And some of those genes we have identified, and we know that they are individuals who their risk of developing colorectal cancer, for all the other lifestyle interventions that might have happened, the weight's gone up, they're drinking excessively, they are higher risk of getting that cancer in the future. So those are the ones we want to ensure are fully aware of their risk and making sure that we prevent them getting a cancer. So the difference between a sporadic, so that is anyone off the street who gets a cancer, they often present later on in life, there's little or no family history, and they often just have one cancer going on. Whereas if you have an inherited condition, they're often earlier in age, multiple generations of a family might be affected. There might be lots of different cancers or multiple primaries within that family, but also that individual, and you get the clustering of certain cancers. I've put a picture up of some elephants, and the reason being is elephants generally don't get cancer. And you think, why? Well, it's not because they've got really tough skin or anything like that, or they've got a very healthy diet. It's actually they've got multiple copies of some of the genes that are what we call proofreading genes. So they go along and do a spell check of the DNA every time it gets copied. And elephants have 20 copies of a particular gene called P53. And it means that if something goes wrong with one of those copies, they've still got another 19 left to go around and check everything. So the chance of them having a gene defect is much less. So actually, they've got it right in their species. Humans, we don't have that many copies. And then these are a couple of guys. So on the right, you've got Henry Lynch, and on the left, we've got Mr. Waldron. And they looked at a particular family. This was across in the States, where it was a seamstress who went along to them and said, look, my family seem to have a lot of cancers going on. And you can see these are massive family trees. And what they were able to map out is that there was a gene involved, or thought to be many genes involved, and the condition is known as Lynch syndrome. But there are other inherited colorectal cancer genes. So there's FAP, or familial adenomatous polyposis. Then that's where people have got generally thousands of polyps within the gut at an early age in their early adult life. And they generally go on to have a total colectomy. We've then got Lynch syndrome, and then you've got other polyposis conditions as well. And they will be under your regional family history clinics, such as the one running out of Southampton. So this is just a picture of all the people that we can think of that have been in the news recently who've got Lynch, or have had Lynch syndrome. But you can see it's young people. And if we can get it right for these guys, we're going to prevent them getting colorectal cancer, but also other cancers associated with this. So it's an autosomal condition. So that means you only have to have one copy of it. And the good copy of the gene, if that gets knocked out, then you end up with a condition. And these genes, there's 4 of them, basically go along and do that proofreading. They check the spelling when the DNA is copied. It affects every race. There is no one who is not affected. You have an increased risk of cancer as you get older because other things go wrong with your DNA. I've put down incomplete penetrance, and that means you might have the condition, Lynch syndrome, but it doesn't mean you're necessarily going to get the cancer. There might be other things going on. And it accounts for about 3% of all colorectal cancers in the UK. And then written in the bottom are some of the other cancers that you can get with Lynch. And there's a lot. So this is just another way of presenting it. But what is unfortunate is we only know about 5% of the population who have Lynch syndrome. So there's 95% of the patients out there who don't know they have this condition and are at higher risk of developing colorectal cancer and the other ones listed there. And we estimate about 1 in 400 people in the UK have this condition. So there is lots of education out there, but it's how we get it out to the public, but also to healthcare professionals, because we're really well placed to have it on our radar and make sure we've done something about it. So just thinking, so these are the numbers, the 1 in 400, but we estimate that we've just got shy of 200,000 people to find, and I'm not expecting anyone to go out there and look for these patients. I think they will slowly trickle through, and what the NHS has been doing over the last few years is they've actually started to embed it. So anyone who gets diagnosed with colorectal cancer will have their tumour tested to see if they have this condition, and if they do have a suspicion that they've got Lynch syndrome, they then go on to have a blood test to see if they've actually got the gene defect. And then that results in cascade testing, so testing family members. And we've also been doing it for endometrial cancer, and then for a specific ovarian cancer called an endometrioid. And those are low numbers, but it started to happen. And we're really fortunate in Wessex that this has been going on, and the testing has been really good. So these are some of the appeals that have gone out to kind of the ICB, to your local Cancer Alliance, and actually it is starting to work. And we've had nurses who have been doing what's called mainstreaming, so you don't have to go off and see a specialist nurse in a genetics clinic to have the testing. It's been done when you see that CNS at the time of diagnosis. And it is working. So just a reminder, it's happening. We've started doing some education, and there will be more education coming over the next 6 months or so across the whole of Wessex, and that will be open up to all of the clinicians. So let's just go through. So this is just a really helpful graph that has come out of those known to have Lynch syndrome, and these on the right, the MLH1, MSH2, MSH6, and PMS S2 are, you can see that this is your risk. As you age, your risk goes up, and this will impact on what age you start having that screening done for colorectal cancer. This is a more detailed graph of what your lifetime risk is, and none of it's 100%, but it's just to bear in mind, actually, depending on the specific gene defect, will then determine what sort of screening you might be offered. And this is changing at a very rapid rate in terms of what that looks like. So why is it important? Because if we can prevent this patient getting colorectal cancer or any of those cancers, it makes a big difference. Making sure they've got the right health education so they know the symptoms and the signs to look out for. Making sure that they've had a discussion about risk reduction, might involve surgery for some patients. And it's a huge benefit to the healthcare system in terms of the cost, because if we prevent them getting a cancer in the first place, even better. Oh dear. Hang on. Oh, okay. So as I mentioned, we've got the screening with the colonoscopies. We've then got CAP3, which is about to publish. And this is looking at the role of aspirin in preventing getting a colorectal cancer. It's currently embargoed, but the dose of aspirin will be coming out. And part of the work across Wessex will be to get that message out to all those patients affected with Lynch, but also making sure that clinicians are all up on to board with the latest advice and guidance. So watch this space for this. Reducing stomach cancer, or checking for Helicobacter reduces your risk of stomach cancer by about 50% if you carry it. So if we can test for it and eradicate it, that makes a big difference, especially for those that you're going to start on aspirin. Gynae cancer, again, just thinking about how we can reduce that. And there is no ideal screening test. You might want to consider surgery, but it might not be in the patient's best interest to have surgery. But it's just making sure that it's on our radar and we've got it coded and flagged that this patient is higher risk. So the take-home message, we know that only 5% of those patients with Lynch syndrome are known. They have a higher risk than the background population for colorectal and endometrial. Not everyone is going to go on to get those cancers, but it's the lifestyle factors that we can really have an influence on, and have a low threshold to investigate and refer on. So what's our role? I've just put it down here very clearly, making sure that we've coded it. And it's really important that if we code it properly, the patient knows it's there, they can see it on their app, but it's also on our radar when they come in with vague symptoms, maybe 5-10 years down the line, and you just think, actually, I need to investigate that, and investigate it early. And it's also important because it flags it to the hospital, so they take this patient very seriously. Making sure that if the patient is new to you in the practice, consider, have they been picked up by the local bowel cancer screening program? And they should have been, but if, just check with the patient, because they will know if when they last had a colonoscopy, and if not, refer, but you refer through the genetics team who will make sure it's flagged appropriately. This is just a whole list of some of the information out there, and there is lots of charitable work going on to support all of this. So summary, we've looked at the increasing numbers of colorectal cancer. We've looked at the screening very briefly, the Never Too Young campaign, so that under 50s, screening versus diagnostic fit, the causes of colorectal cancer, and there's lots out there. Some of the amazing local improvements to raise awareness of cancer, especially bowel cancer. And I think what you've got on the Isle of Wight is brilliant with those toilets, because I think that's really going to have a message, making sure we're coding, think about genetics and what impact it has on us as GPs. And then finally, I think that's it then.
Okay.
Yeah, all done. Thank you, David. And thank you for listening.
We've got to try and get out of this now, haven't we?
If I stop control.
So you're going to do it? You've done it, okay.
I don't think I can shut that window.
Okay, I think I can do it now.
Ah, you've done it.
Everybody's there. So, we've got a couple of minutes. We've got 1 minute left. Has anybody got any questions? I mean, we've done a bit of death by PowerPoint now, I'm afraid, but so if you've got questions and you're shy and don't ask them now, then you can mail me or Nikki. And if you've got, Haf's got coming up with something. Haf, what do you want?
Yeah, just say really, really interesting. Thank you, both of you. That was a really, really lovely sort of overview of what's going on. I put my question in the chat, but essentially it's something a bit more logistical. I appreciate we've got Peter on the online as well. Just in regards to the fit test that we receive through on the Isle of Wight at the moment, because they are looked at on the mainland, they kind of come through as appearing normal, being black. We've had a few incidences across the island whereby they have been marked as normal accidentally because they've looked black, and whether that can be looked at sort of on a more sort of wider level, and might be something you've already tried to tackle already multiple times, but just put it out there. Yeah, thanks, Haf. That's a great point. And what I'll do is I'll contact Kelly Speller, who's our liaison point between the labs and the Cancer Alliance, because we've had our whole fit testing has been a bit rubbish on the Isle of Wight. Let's not beat about the bush. There was an inordinate delay because the specimens go to Portsmouth. Then instead of getting electronically just sent straight back to us, they get sent to our lab, they get looked at again in our lab, and then they get sent out. So that's been eradicated now. But you're right, part of the reason I'm told is that the fit testing machine costs 6 million, and they don't want to change it to a nice compliant machine because it's too much money. But I'm sure that machine will wear out and break down in times, and then we'll be able to have the same one as the rest of Wessex. But we've got uniquely hit on Portsmouth and the Isle of Wight with a machine that isn't nice compliant in terms of the tech it's using, apparently, and also in the reporting. So yeah, that's a good point, Haf, and I will send a message to Kelly Spiller in a minute.
Yeah, and it should be straightforward, because that's just an IT.
Yeah.
Someone needs to make sure it remains flagged and read, because it's so easy to just kind of go through and tick everything, and then you've forgotten, well, who's the patient? And yeah.
And they put a link in there, but who's going to get through to the link saying actually the real answer is 10 every time they look at set of path results? Yeah.
No, it's tricky. And I think it's also confusing for your patients on the island, because you're having two different fit kits coming through. One is the screening, and then you've got a different one for the that goes through Portsmouth. So it's not ideal.
No.
But I think you flagged something that has already been pushed, so we're trying to get that improved. There was another question in the chat. So this is from Himanka, and she asked, what do you mean by excess nutrients? Unfortunately, she had to leave. But what I was going to say is, this is looking at some of the information about your metabolic health. And if you are if you're having a lot of nutrition, and in particular, I'm referring to carbohydrates, that has a push on your insulin. So you often typically it's your people who are insulin resistant, but insulin itself is very pro-inflammatory, and there's lots of inflammation going on. So it's kind of thinking, well, what's going on with our diets, not just thinking about the actual bowel flora, because that will have a huge impact on our risk of bowel cancer, but also what's going on within the whole body. So I think this is a whole new area. And I am going to a talk at the weekend where it's going to be looking at that, because you just think, if we can unpick that and people can make easy lifestyle modifications, that might have a massive impact on our future risk.
That certainly looks like a fun conference.
Yeah.
It's all sorts of weird stuff in there. Right. Okay, well, thanks everybody for coming, and there'll be a recording for your colleagues. Sorry about a slight distortion. I don't know if anybody else had slight distortion with Nikki, but sometimes these things happen, don't they? Good, and thank you for Peter for organising it. It's great. Okay, and if you've got other questions, then contact me, and I can probably ask Nikki. Okay. Thanks everybody.
Okay.
Bye.